We'll talk a little bit about maintaining fluid and electrolyte balance. And according to your course outline, our class objectives for this is to develop an understanding of the nursing process across the lifespan for individuals with fluid and electrolyte imbalances. So we'll talk a bit about the different fluids and the different electrolytes that need to be replaced, and then we'll go on and talk about blood products. So firstly, let's understand a little bit about the water content in the body. So there's two major fluid compartments in the body, and one is in the intracellular space, so the fluid that's held inside of cells, and the other is your extracellular spaces. So that's the fluid that's outside the cells. So your extracellular fluid is your interstitial fluid as well as your plasma. So you need to understand where your fluid is so that you can make sense out of shifting of fluids. When we're looking at imbalances, we're looking at extracellular fluid imbalances. So when you think of the lab coming and drawing a blood sample, the electrolytes that we're monitoring are in the extracellular fluid. So we're not opening a cell and looking at the fluid that's inside the cell. What we're looking at is the fluid in that serum space, or your extracellular fluids. So if we have extracellular fluid volume deficit, we have hypovolemia, right? Decreased extracellular fluids. So that's from abnormal losses of normal body fluids. And of course that would happen with, say, diarrhea or hemorrhage or any type of fluid loss. It could also be from inadequate intake or a plasma to interstitial fluid shift. So when we have, we'll talk a little bit more about albumin, but if we have low albumin, we have trouble keeping fluid in our intervascular space. So fluid leaves our vessels and hangs out in that interstitial area instead. So treatment for fluid volume deficit would be to replace the fluid and the electrolytes with a balanced IV solution. And we'll talk about the different IV solutions here shortly. So when we have a extracellular fluid volume excess, that means that we have hypervolemia. So excessive intake of fluids, abnormal retention of fluids. So in the case of heart failure or renal failure, the chronic liver failure with portal hypertension will cause excess fluid volume. And sometimes it's in that wrong area, right? So the treatment, of course, would be to remove the fluid without changing the electrolyte composition or that osmolality of your extracellular fluid. And that would be done with diuretics or fluid restrictions, restrictions of sodium. You got to remember that wherever sodium is, fluid likes to follow. So think of everything that we're going to talk about in your cells is around the amount of sodium, because sodium makes water follow it. I hope that makes sense. So our electrolytes, they're substances whose molecules split into ions when they're placed in a solution. So you've got your ions, which are electrically charged molecules. You have your cations, which are positive, and our cations are sodium and potassium and calcium. And then our anions, which are negatively charged ions, and that would include our bicarb or chloride, phosphate, those types of things. And I know Jody would have talked a bit more about that. So whenever there's a fluid and electrolyte imbalance, we need to find the problem and correct the problem to help the body return to what's called homeostasis. So, and again, to remember, when we're looking at the fluid content, we're looking at an excess or a deficit. So how do we correct a deficit? And that's going to be with our IV fluids. And IV fluids that contain no proteins, so it's just fluid, supplies water and sodium, possibly other electrolytes, is called your crystalloids. So crystalloids means that it is a plasma volume expanding capacity, and it can give, like I said, different electrolytes, but it gives no proteins. So the purpose of using crystalloids is for maintenance if a person can't take fluids in orally, or for replacements when someone has had losses of fluids. So there's three different types of crystalloids that are available, and one of them is called isotonic, one is hypotonic, and one is hypertonic. So an isotonic solution means that it has the same concentration of sodium as what naturally occurs in your body. So there's no net loss or gain in that intercellular fluid. So it doesn't cause a shift of fluids into the cell, and it doesn't pull fluids out from a cell. So it's a fluid that would be used for a patient that has just an extracellular fluid volume deficit. So we're replacing those fluids. And our choices are 0.9% normal sodium chloride, or normal saline it's called. Sometimes you'll see it called NaCl, normal saline. And another one is lactated ringers. You might see it as Ringer's lactate or lactated ringers, depending on the manufacturer and what your agency calls it. But again, it's an isotonic solution, and it does contain some sodium, potassium, chloride, calcium, and lactate, and but it still has the same concentration of those as what's inside a cell. So it's still considered isotonic because it doesn't cause a shift of fluid between the extracellular and intercellular space. There is a dextrose 5% in water that's called D5W, and then there's a fluid called 2/3, 1/3, which is 3.3% dextrose with a 0.3% normal saline, and again, it's considered isotonic. So a hypotonic solution means that it has less solutes in the solution than what's inside the cell. So there's more water than there is electrolytes, and so it dilutes that extracellular fluid. So osmosis then produces movement of water from the extracellular fluid into the intercellular spaces. So the one that is available is called half normal saline, or 0.45% normal saline. So the last one I wanted to look at is your hypertonic IV solutions, and they have a greater concentration of solutes than the plasma, so it causes fluid to move out of the cells and into that extracellular fluid space. To help normalize that concentration, right? That movement of cells. So this effect causes cells to shrink, and sometimes it can cause them to shrink too fast, which disrupts their function. But the other thing is that they're considered fluid volume expanders because it pulls fluid from the intercellular space into that extracellular fluid volume. So it can raise your blood pressure, it can cause a fluid shift into the lungs. So we need to monitor these patients quite closely. Now you'll see D5W and half normal saline is listed here. Dextrose is a hypertonic solution, so you'll see D5W up here in the isotonic. But what happens is the dextrose is metabolized really quickly, so then it really um, is only a temporary shift, so it turns into an isotonic. So D5.5 normal saline here really is a hypotonic solution because the D5W is metabolized really quickly, leaving just an isotonic solution. So hypertonic, the one that is most common is at 3% sodium chloride. There is a 5% sodium chloride. They do need to be used with caution because of that fluid shift. So just to make sure that your patient's on a cardiac monitor and you're listening to the lungs really closely. Um, Anything with dextrose, so there is a 10% or a 50% dextrose, they are considered hypertonic solutions as well. But again, the dextrose is metabolized very quickly, leaving that either an isotonic or a hypotonic solution. So just keep that in mind. The biggest risk is with our high sodium content, 3% or 5%, because that does cause that fluid shift, and we want to make sure that our patient can tolerate that and that we're monitoring them very close. So those would be used in ICU or critical care places, those types of things. So things to remember when you are using crystalloids or IV fluids is that they are safe, they are effective in replacing fluids, but they can have some of those unwanted effects. So because they contain no large particles, so they don't have proteins, they stay in the fluid vessels. The protein helps hold fluid in the vessels, so as we dilute the proteins, we can have a fluid come out of the vessels and cause some of that edema or that interstitial type swelling. And we need to monitor any edema, so peripheral edema, pulmonary edema are a couple of examples. And we can see that as the protein becomes more diluted, it reduces that colloid oncotic pressure, which means that fluid leaves your vessels and hangs out in that interstitial areas. So keep that in mind. It would be like a fluid overload. So we wouldn't want to put someone into heart failure because we've used too much fluid. So this picture is out of your textbook, and it looks at what happens to cells, so our red blood cells in this example. If we put the cell into a hypotonic solution, so we have less solute in the solution than what is in the cell, fluid by osmosis goes into the cell, causing an expansion or a swelling of that cell. So isotonic, we have the same amount of solutes in the solution as we do in the cell, so it doesn't change your cell at all. And in the case of using a hypertonic solution, it causes shrinkage to the cell. So we have a high sodium content which pulls fluid from the cell out to the into the extracellular space. So just an example or a picture of what happens to the cell when you're using a hypotonic or hypertonic solution.